So thanks, Steve. What you don't know is we've talked a lot about teams and team training at various levels during the day, but this is the first time we've looked at it from a health system perspective, sort of big data, big messy data, and the ability to crunch that data into ways that may be answering some of the key questions. So let me open this up for discussion, first from the committee members and then the general audience, if I might. So, committee, Brenda Zerler.
Hi, Steve. Brenda Zierler from the University of Washington. Go Huskies. You presented some wonderful data, and I've been very impressed and actually involved early on when the VA started this and was able to participate in some faculty development around team-based care. And I guess some of the measures that you've shown, there was two things going on when the PACT and the IPE was implemented, and that was practice changes in the way the organization actually delivered and primary care measured and et cetera, along with the team training. And I know each of the 5 VAs implemented team training differently. And what I want to know from you, though, is you showed some data that there was some big discrepancies in those measures between the some sites, the worst outcomes and the best sites. Have you looked at best practices for those sites that were really high functioning around the satisfaction and the teams, and to see what they were doing differently when your organizational intervention was very similar with PACT?
So that's an excellent question, and that's the, finding the bright spots and understanding them and exporting them. And we're starting at this point to do that. We had a lot of this work was done by a group known as our demonstration labs. I won't go into detail, but we had 5 of them. Lisa Rubinstein, for example, leads one of them, and we just sort of recompeted them and refunded them. And their main task is to do just that, to try and go out, find these places. We, initially had trouble figuring out who they were. That was the whole point of this pi-squared exercise, was really not so much as a system gauge, but as a locator for the places that seem to be doing it well. Because the original set of measures we used that everybody else is using, if you look at the literature, really don't tell you. I mean, hemoglobin A1C control or blood pressure control or, these slight differences don't really get at the places that are really doing it. And they don't correlate very well, to be honest, with those outcomes we looked at, nor do, for example, just the raw staffing levels or the square footage or many of the sort of basic measures that were put in place at the outset. So now that we have this in place, we're going in and starting to look, and that is going to be try to figure out what they did and to the extent to which it can be exported. The sort of overarching question here really, and then, I think we really going to have to grapple with, is to what extent are these just reflections of really functional institutions, ones that have good leadership, good culture, and are able to successfully execute the implementation of complex programs. I mean, some of this may not just be PACT specific. It may be the fact that they've just, they're like Intermountain. They're like Mayo. They're like Cleveland Clinic. They are able to do these things that many less functional places can't easily do. So I think teasing out what are sort of transcendent qualities of an institution versus what are the, sort of unique processes and policies and practices they put into place in implementing PACT will be, both of those will be, I think, informative. Does that answer the question?
Yes, it does. And I just want to know, were there any preliminary team-based measures around the culture or the, like almost the team steps, TPQ, a baseline survey of teams? Was there any of that with the 5 sites, and did any of that correlate with the outcomes that you measured?
Well, they're in that index. So yes, they are. It turns out they're not huge contributors to explanation of variance. So they're part of the puzzle, certainly not the whole puzzle. And again, part of that may be the degree of variation. I think if you recall, the recent report on the VA from the White House that was given to the president, I think referred to a corrosive culture. Like many places in primary care these days, morale is low in primary care. It's particularly low among our nurses, but also among the physicians. And it's low across the VA, and a bit lower than most other places. In general, across the country where it's looked at, morale in primary care is bad, and burnout is high. So, again, I don't know for sure. Are there places where everybody's running around, wildly happy and enthusiastic, and, we'll look and see at those, but, some of them may just reflect the general sort of climate, environment in the organization as well. We do know, however, that in places where the team function is better, provider burnout is low. They're more optimistic. Having, the team's function better, is good for morale and is related to patient satisfaction. Some of the other outcomes, not necessarily, and maybe those are more related to other types of systems.
Thank you.
So, Steve, having this data set of variation enables you to answer or to question some of the modifiers and enhancers, and both positive and negative. We're primarily interested in education, and I know there wasn't any particular early education around trainees in this effort. In the national rollout, there wasn't. But there was a lot of money put into, as I recall, education of providers. So call it training of one sort or another in the practice environment. Have you looked or had the opportunity to look at whether that helped and explained some of this large variation that you described?
Well, I think the picture is mixed. And we do have some internal sort of disagreements about the interpretation of those data. So I'll qualify anything that I say with the caveat that, this sort of represents my view. I know Rich Stark, who's our Director of Primary Care Operations, has indicated, shown that there appear to be better measures among places that did undergo the training. There was a lot of training. There was team training. There were collaboratives. In general, the training was not rated terribly high. And actually, I think part of it may be just the challenges of doing training in a very large system. For example, we were asked to start to evaluate the collaborative data, and actually we declined to do that because the first thing I asked for was, can we see the training logs, the people who attended? And when we just looked at those, we saw that, for instance, there were whole facilities that never sent anybody. There were some facilities that would send a single team, but then it turned out that, this is based on a train-the-trainer model, and that when they got back to their facilities, they were never given the time or resources to train the other teams. And so there was great heterogeneity in how there was participation in the training, how effective it was. In general, I think that's something you guys really need to struggle with, is, when you're taking a bunch of very, very busy practitioners who are expected to be highly productive, and you're asking a lot of them, how do they change their roles and, interact differently and take on new tasks, and yet, the environment for conducting that training and making sure that it's truly viewed as relevant and effective, I think it's hard. And then linking it actually to the process that's in place. Because it's one thing to tell the nurses that we no longer want you just to check in patients and room them and participate in all these other, all these other activities. We also want you to step back and be a population health manager and do case, help do care coordination, and they look at you and say, well, I still have the same number of phone calls. I still have the same number of walk-ins. You've trained me a bit to do this stuff, but you haven't figured out how now I integrate that into my regular work. And I think that's been intensely demoralizing to people to sort of feel like, in some ways, the training, I think, was almost viewed as a negative because it wasn't linked really to the process changes that needed.
Thanks, Steve. Other questions from the committee or the audience in general? Maddie, if you'd introduce yourself to Steve, I think that would be helpful.
Steve, I'm Maddie Schmidt from the University of Rochester, professor emerita there, and I'm part of the IOM forum. I'm wondering whether in your analysis you looked at from each of the individual systems of care within the larger VA system, you identified a series of things that had happened prior to the PACT introduction, and I'm wondering whether you looked at whether each of the organizations or institutions had those characteristics preceding the PACT introduction, or whether there was variation in how much uptake there had been on some of those earlier variables.
Well, I think it was pretty uniform. I mean, most of that stuff was, mandated. I mean, our office, I direct the Office of Analytics and Business Intelligence. We distribute the performance measures. And they're distributed, as Malcolm and other VA folks there well know, consistently and have been for years. People are expected to attend to them, to pay attention. Again, everybody had to use the electronic health record. There was, although variable degrees, I'm sure, there was social work staff, there was pharmacy staff, there were health educators. Again, in terms of those measurable kinds of components, I think they were pretty uniform. Now, if you're asking the question, did everybody start at the same place? I'm sure that's far, far from the case. I mean, there have been places, a good example was Grand Island, Nebraska, which had 3 years earlier decided to undertake the patient-centered medical home model. And, it already got a head start. They were, very far along. There were some of our Vision 8 being a good example, or Vision 12 that had already, Vision 1, Vision 20, the numbers don't mean anything, so Chicago, Ohio, New York, California, the Vision 23, Minneapolis, and the upper Midwest, that had all sort of really invested heavily in primary care and, started to really move forward. So there were unequal baselines, but not necessarily so much in those measurable components. I think it was, the leadership and the sort of less easily measured baselines. And I don't know that we have good ways to have captured those, which would have been wonderful if we'd had, say, that pi-squared measure back in 2010.
Thanks.
Other questions? Scott Reeves, who's a member of the committee.
Thanks, Malcolm. Just a quick question, following up from Brenda's point. You said, Steve, that you were going to look for variance, but I wasn't clear whether you were going to do that empirically or whether there was going to be some sort of site visit, because it strikes me what sort of is the next step is some kind of ethnographic work with, using some kind of symmetrical analysis, looking at your outliers sort of positively and sort of negatively to get a better sense about what's going on. Because one of the problems with big data is that we have great broad perspectives, but we lose the detail. And then we can't provide explanations for why things are happening in certain contexts and why they're not happening in others.
So I couldn't agree with you more. I mean, I'm a big fan of big data, but I'm also a big fan of little data. And I think what you're saying is, now that we have this sort of roadmap, one. And so we're asking, first of all, although I think the data that that I presented to you and other data that I haven't suggests that the pi-squared analysis is somewhat robust. I agree with you. It needs to be validated sort of with the proverbial boots on the ground look and sort of going in and understanding. And then what are the qualitative correlates? What's interesting of that last section I presented to you with those 7 things, most of that actually was the result of qualitative, observational, anthropologic studies of facts. So there actually was a detail. The folks at Iowa, for example, did a very detailed observational analysis at Grand Island, the one place that I talked to. And even though that was one of our leading spots and it was out there, they just were able to enumerate a number of the sort of barriers that at that facility that individually they face. So we have been, trying to correlate, some of this work with our qualitative work, but I agree. So the first step is both to gather more data and to sort of validate the big data metrics, is to have people go and spend some time and observe in those clinics, and that is the charge to our demonstration labs, beginning, this past October 1st. So hopefully we'll do that. Easier said than done, obviously. It's going to be a big effort, but I agree with you. I think it's a critical step.
Other questions? Just a comment, Steve, but before we let you go. Perhaps if you stand back and look at the forest and not the trees so much, the remarkable thing, in my view, of this work is that the VA funded it, and it cost a lot of money. It set up 5 demonstration labs to do these analyses, and Steve heads up that effort. And even more remarkable, it's staying in the race. That is, it refunded. And I think I saw Brenda's eyes open when you mentioned that, Steve. And that kind of consistency and persistence and creating data that can be manipulated to either do deep dives in small areas or do real big data analysis is absolutely critical. And the bottom line is the support for this didn't come from education. The support for this came from the health system and convincing the leadership that this was important to the health system to transform the practice of care in this, or enhance this already existing team-based care in the VA. And that, I have to say, is pretty impressive. So
I didn't hear that last comment from someone in the audience.
Dr. Wu.
Thanks, Malcolm. Steve, this is a very impressive work. Thanks for sharing with us. Since you've been refunded, I was wondering if you had at all considered the possibility of doing some actual experiments. I know that you're not interested in interprofessional education as much as this group is, of course, but it does seem like you observed a lot of natural variation. Have you thought about inducing some variation in style of training, time of training, intensity of training, and so forth? That would be very, very pertinent to what this group's all about, and you might have a good opportunity.
So let me just respond to that in a second. I just want to respond to Malcolm, just to put that in perspective. There are many things, lately which we can, beat the VA up over. This one, I think, stands as a real tribute to the foresight and thoughtfulness of our leadership. I mean, so far I think we've probably invested about $50 million in the evaluation. In fact, you know, people's jaws would drop. But remember, that's 1% of what, you know, the initiative costs. You know, it's been about $500 million a year. Or 2% again. So, you know, thinking that, you know, I think, you know, you could turn that around and that it would be irresponsible of the health system to make those kinds of investments, you know, particularly with public money, and not, you know, do their damnedest to try and find out if that money was being spent effectively. So that doesn't, you know, we all know that rarely happens. But the fact that this wasn't a retrospective analysis that, you know, often happens where it gets done and then someone says, well, let's go back and see what happened. You know, we did this in tandem with the development of the health system. Now, that said, as I said, it wasn't experimental, and would it have been a good idea to do it? I mean, it would have been relatively easy and probably a better idea to sort of pick 500 sites, say we're doing it here, and not do it at the other, or, you know, do some sort of step wedge kind of design. You know, I wasn't consulted about that one. We are, for example, doing some experimental studies related to management of our highest risk patients, sort of the different models for primary care and intensive management, which remains a really Achilles heel for this model. It's not being as effective as we want in taking care of the most complex, chronically ill patients. We get lost in those panels of 1,200 people, and the question now is, how do we do that? Could other educational interventions be done on an experimental basis? I think so. You know, Malcolm, I just talked to Bob Jesse this morning. You know, maybe that's a conversation we could have with Bob about that. I think it'd be receptive. You know, I think the environment for doing randomized types of introduction of its, you know, of operational initiatives in functioning healthcare systems is changing. You know, 5 years ago, I think the foundation for doing that was weaker than it is now, largely, I think, due to the IOM's work related to learning healthcare systems. I think we have now sort of both a literature and philosophical basis that, you know, will give us a better basis for arguing in favor of these kinds of interventions. So I think the answer is theoretically yes. I got to say, we don't have plans right now, particularly with regard to the educational aspects. There are, as Malcolm well knows, because he initiated them, I think 4 or so sites that are charged with looking at the educational aspects of this, and maybe they could be charged to take a leading role in it. You know, I'd almost punt that one back to Malcolm.
Well, thank you, Steve. There being no more questions, I'll thank Dr. Fihn on behalf of the committee and the forum, and let you get back to your day business, Steve. Thanks so much.
On the other side of the room.